Good morning, good afternoon, and good evening. Welcome to IFSO 41st webinar. My name is Hazim Al-Momani, consultant bariatric surgeon from Abu Dhabi, the United Arab Emirates. And it brings me the greatest of pleasure to welcome to today's webinar our colleague, Professor Barham Abudia from Mayo Clinic, Rochester. Professor Abudia is well known for his publications and massive contribution to endobariatrics. Professor Abudia is a professor of medicine and the director of advanced endoscopy. Professor Abudia will be talking with us today about his recent publication in obesity surgery, talking about the correlation between the size of the gastrojejunal anastomosis and the Roux-en-Y gastric bypass, talking about the diameter of the anastomosis, the distendability index, and the likelihood of weight gain recurrence after such surgery. Without further ado, I pass the mic to Professor Abudia. Welcome.
Thank you, Hazem, for the opportunity, and thank you, IFSO. It's a great pleasure to be with you and looking forward to this journal club and to take a deeper dive into the issue of weight recidivism after gastric bypass.
Fantastic. All right. I believe, Baram, you've got with us a recording of your talk. So we'll roll the recording and we'll start taking questions afterwards. And feel free to chip in during the video if you've got any comments along the way, please.
Sounds good.
Hello, colleagues. My name is Barham Abudia. I'm the Director of Advanced Endoscopy, Professor of Medicine at the Mayo Clinic in Rochester, Minnesota. It's a pleasure to be with you and for this IFSO Journal Club discussing our paper published in Obesity Surgery entitled Correlation Between Gastrojejunal Anastomosis Diameter, Distendability Index, and Weight Regain After Roux-en-Y Gastric Bypass. I acknowledge my co-authors on this paper, highlighted in this title page. These are my disclosure as it pertains to this paper. Before we take a deep dive into the findings and the results of the paper, it's important to put it in context about the milieu that results in weight regain, or better referred to nowadays to weight recidivism after Roux-en-Y gastric bypass. And it's a complex interaction between genetic factors, modifiable risk factors related to the anatomy, which we're going to be focusing on and discussing today, and then, of course, environmental and psychosocial determinant that could interact to result in an environment conducive to weight regain or recidivism. So again, we're not going to talk about genetics. We're not going to talk about environment and psychosocial here. Here we're going to focus on modifiable risk factors related to the bypass itself that could be targeted for therapies in order to help the patients with their weight regain journey after the bypass. The two well-known anatomic risk factors are formation of a gastrogastric fistula, which is an opening between the pouch and the excluded stomach. Oftentimes, it's at the staple line, as shown in this image. And the second one that has been established is this relation between the dilation of the gastrojejunal anastomosis and the weight regain after the procedure. The correlation between the gastrojejunal anastomosis and weight regain has been established through multiple cohort studies. These are two studies, one here that looked on a regression analysis on the x-axis is the diameter of the anastomosis, and on the y-axis is the percentage of weight regain from nadir weight. And you could see that there is a nice linear correlation showing that the wider the anastomosis, the more the weight regain. Similar phenomena has been described by a different cohort study showing that an enlarged pouch and stoma are associated with higher weight regain after the procedure. Now, when you ask yourself, why is that? Why a dilated gastroduodenal anastomosis results in more weight regain? You go back to the issue of hunger, satiety, and satiation, and the eating behaviors of these patients. I mean, a component of the gastric bypass is restrictive, and logically speaking, if the anastomosis is wide, you could see that the restriction is decreased, and the patient appetite pathways are less regulated compared to a restricted or a narrowed anastomosis. So if you look here on this study that we performed, that looked at the association on the x-axis between a blinded measurement of the gastroduodenal anastomosis and objective measures of eating behaviors, such as uncontrolled eating on standardized questionnaires called TFEQ-R21. And you could see here, there's another linear association that the wider your anastomosis, the gastroduodenal anastomosis, the higher your uncontrolled eating score on that questionnaire. And this holds true after you adjust for the BMI of the patient and the percentage of weight regain. So it's not a function of the recurrence of excess adiposity per se. My colleague, Dr. Christine Stier, did a nice study that illustrates this concept, where she did a radio-labeled nucleotide meal and looked at the rate of meal emptying after the gastric bypass. You could see before the meal quickly empties. This is the peak of the emptying, really rapidly within minutes after ingestion. And most of the meal is sitting in the small intestines after. When you restrict the anastomosis, and in this study she did a TOR-E or transoral endoscopic reduction of the gastroduodenal stoma to restrict the diameter of the anastomosis, you could see now there's more regulated emptying of the gastric pouch. So the emptying of the gastric pouch is delayed over time, and now you regained restriction back, and patient described better control of hunger, satiety, and satiety signals. But the equation is not that simple, because this pouch reconstruction and connection to the small intestines is really a complex interplay between two things. There is the restriction, which is a function of volume of the pouch, dimensions of the pouch, the diameter of the gastroduodenal anastomosis, and also the compliance of this whole structure of both pouch and anastomosis. Because compliance is important, because in the bypass we know there's two phenomena at play. There is restriction happening from this anatomy of the pouch and its connection to the gastroduodenal anastomosis, but also there is small intestinal pathways, incretin pathways, bile acid circulation pathways that are activated by the rapidity of the food bolus making it to the small intestines to activate both fore and hindgut pathways implicated in the mechanism of action of the gastric bypass. So To me, it never made complete sense to rely on one measurement as the absolute truth of this complex interplay between such a complex anatomy and the weight regain, especially in context of the global interplay of other factors associated with that phenomena. So to me, in this paper, we wanted to take a deeper dive to evaluate metrics beyond just looking at a two-dimensional measurement of the diameter of the gastrointestinal anastomosis. We wanted now to use new technology that allow us to measure the compliance of this anastomosis and get an idea about the dimension of the pouch in order to incorporate them in a simplified algorithm that help us or possibly could help us triage our patients in order to better utilize resources and maximize patient outcomes. So this technology that we used for the purposes to go beyond just 2D measurement of the gastrointestinal anastomosis is this technology of impedance planimetry system. So let me describe the technology. It's a 16 centimeter balloon that is quite flexible. It has impedance sensor. These sensors detect changes in volume and diameter. And you could see when you place the balloon across a structure and you inflate it to a certain volume, the contraction within the structure determine two measurements or two outputs from that balloon. One is the diameter plotted over this 16 centimeter sensors, and you could see here the balloon is at the GE junction. It's giving a reading of a diameter of about 10 millimeters, and also it's giving you a distensibility index, which is pressure over volume. And here's the distensibility index that it's giving us at that diameter is at about 2.61 at the GE junction. So we wanted to utilize this technology in order to study the diameter with a more 3D objective measure of the gastrointestinal anastomosis, and to also understand the variable of compliance, is how compliant is this anastomosis, and how does that play into the phenomena of weight recurrence after row Y gastric bypass. So we utilized this impedance planimetry, or I would refer to it moving forward as EndoFlip, in order to have a fluoroscopy guided placement of the balloon. You need fluoroscopy in row Y gastric bypass because you need precise positioning of the balloon across the gastrointestinal anastomosis and across the GE junction to get the diameter. Here you could see the diameter of the gastrointestinal anastomosis and the distensibility of the gastrointestinal anastomosis. You could get an idea of the length of the pouch, and you will get also the diameter and the distensibility index of the GE junction. So we utilized fluoroscopy to place that balloon precisely in this configuration to span the gastrointestinal anastomosis and the GE junction to get a measure of diameter in a 3D fashion and compliance of that anastomosis. And as you could see, this is important because now if you could create an algorithm, we have treatments. If what's driving the patient weight regain is truly a dilated gastrointestinal anastomosis, as you could see here, we could use argon plasma in order to treat this. We could use mechanical suturing devices, and we could use plication platforms in order to modify the gastrointestinal anastomosis and the pouch for that matter in order to treat the weight regain. So with this context in mind, let's take a deeper dive on the results of our study. We'll start with a design. With the design, is we subjected our patients undergoing upper endoscopy to be potentially eligible to get the endoflip procedure. Now, we had to exclude many patients with diameters of their gastrointestinal anastomosis above 30 millimeters, because the balloon volume, or the balloon diameter, goes up to 30 millimeters. So if your anastomosis is wider than 30 millimeters, you will not have apposition, and you will not have accurate readings with the endoflip balloon. So we took the 34 patients. 7 had a diameter above 30 millimeters. We analyzed them for the endoscopic version of the study, and 27 patients got both measurement with endoscopy of the length of the pouch, the diameter of the gastrointestinal anastomosis, and the measurement of the compliance, and the diameter with the endoflip catheter in the study. Here is the total cohort, and the cohort with the diameter of the gastrointestinal anastomosis less than 30 millimeters. You could see that predominantly, this was a female cohort. The patient preoperative BMI was at about 45. They achieve a nadir BMI of 28 after the bypass. So these are patients who were responsive to their initial bypass. There was significant weight regain from nadir at about 25 kilos or so. And then here is the BMI at the time on the endoflip, and the percentage of weight regain from nadir of about 50%. And these patients were years down the line after their gastric bypass, with a median of about 13 years. So the first part of our study was to confirm previous associations that have been described in our previous study, and you could see we were able to confirm that. If you look at the endoscopic measurement of the gastrointestinal anastomosis on endoscopy here, not endoflip, this is previously known, and the weight regain on the y-axis, you could see a similar linear association, indicating that the wider the gastrointestinal anastomosis, the more the weight regain. Now, interestingly, we lose that association once we remove gastrointestinal anastomosis above 30. That means in a zone where the anastomosis is between 10 to less than 30, this association becomes flatter and not statistically significant, indicating the need for a more sensitive and more precise 3D measurements of both the diameter and the compliance of the anastomosis. And that's where we did the endoflip, and you could see that in this cohort where the diameter was less than 30 millimeters, now we have a slightly different correlation, in that in this cohort where the anastomosis is between 20 to 30, you could see a negative regression line indicating a negative correlation between the diameter and the weight regain, telling us that in this cohort with an anastomosis less than 30, that a slightly wider anastomosis might be more advantageous as far as weight regain. So we were perplexed with this finding, and that's why we took a deeper dive to study the compliance, not just the diameter, using the end-of-flip planimetry. And here we've seen a uniform and quite statistically significant association between the compliance of the gastroduodenal anastomosis and the weight regain. And again, it's negative regression line with an R that is negative. And you could see at all volumes, this association is highly statistically significant. And what does that tell us? It's telling us that for gastroduodenal anastomosis, less than 30 millimeters, or between 10 to 30 millimeters, the more compliant the anastomosis, the less the weight regain. So the more stiff the anastomosis, the more the weight regain. So when the anastomosis is less than 30 millimeters, a compliant anastomosis, independent of the diameter, seems to be advantageous for less weight regain or weight recurrence. So with that in mind, then, we classified our cohort into two drivers as far as pouch dynamics and anatomy for weight regain. There's a group that have significantly dilated their gastroduodenal anastomosis, as indicated by a diameter above 30. And this group, what's driving their weight regain is a lack of restriction. And with this group, modifying the gastroduodenal anastomosis or reducing its diameter is highly advantageous in treating the weight regain. And these are the group that we classified as type 1 or patients with type 1 weight regain. That means you do their upper endoscopy and investigation, you find an anastomosis above 30. This group, clearly, they have lost the restriction, and now you could move with a procedure to modify the anastomosis in order to help manage their weight recurrence. When the anastomosis diameter is normal, less than 12 millimeters, obviously, neither the diameter or the compliance of the anastomosis matters. This is normal anatomy, and we cannot fix normal anatomy, or we should not fix normal anatomy. And with this cohort, the patient should be referred to a multidisciplinary team to manage the other determinant of the weight regain, the psychosocial determinant, behavioral and nutritional, and these patients should not be offered a restrictive procedure because their anatomy is normal. Where it gets interesting is when this diameter is between 12 and 30 millimeters. And that's where the story becomes more nuanced and more, and that's where the compliance of the gastroduodenal anastomosis becomes important, because here we're going to introduce a new concept, and this concept is type 2 weight regain. That means there's a group that what's driving their weight regain is not the loss of the restriction. On the contrary, is a group that is what's driving their weight regain is the decreased rate by which the food bolus is making it to the small intestines to activate the enteric pathways, such as incretins and bile acid circulation, in order to modify appetite and the metabolic parameters. So the type 2 is a group that would benefit from a more rapid emptying of their gastric pouch in order to activate small intestinal pathways implicated in the mechanism of action of the bypass, and that is what's driving their weight regain. And how do you differentiate between this group? You measure the distensibility of the gastrointestinal anastomosis. So if the gastrointestinal anastomosis distensibility is low, then you could proceed with a TORI, and here the cutoff based on our initial modeling is less than 7. However, if the distensibility index is high, that means this group could benefit from enhancing the emptying rather than restricting the emptying of their gastric pouch. What we would recommend based on what we observed, at least in principle, is to reduce the volume of the gastric pouch to make it smaller without altering the gastrointestinal anastomosis, to allow the pouch to become to empty rapidly in order to manage the weight recidivism or the weight regain in this patient. So in conclusion, I think the anatomy of the pouch, the gastric pouch, and the gastrointestinal anastomosis is complex. It goes beyond a simple diameter measurement. We're seeing that complexity in the study that we observed here. Hopefully, we introduced a new concept of there's a type 1 weight regain when it comes to the geometry of the gastric pouch and the anastomosis, and that type 1 is a dilated gastrointestinal anastomosis above 30 millimeters, and this is causing less restriction, and now you should reduce the diameter of that anastomosis to manage the weight regain. But then there is a cohort that is less understood, and we need to have more research, which is the type 2, and this cohort is what's contributing to the weight regain is not necessarily the lack of restriction, but the lack of activation of small intestinal pathways. And this group could be detected by a highly distensible gastrointestinal anastomosis on endoflip, and this group benefit not from restricting the outlet of the pouch, but reducing its volume in order to make it empty rapidly to the small intestines and manage the weight regain. Obviously, there's limitations to our study, and one of the limitation is the small sample size, but to do these testing on patients is not easy. So I think we need to confirm our findings in larger prospective cohorts and take a deeper also dive into physiological determinants as well. However, I think this is a nice first step to understand the complexity of the weight regain after a procedure like gastric bypass and help kind of stratify patients in order to offer more of a precise and personalized medicine paradigm to maximize the outcomes and minimize the risk. And with that, I thank you for your kind attention and happy to take any questions.
Barham, thank you very much. It's an interesting concept, right? I'll get the questions going. We've got questions coming from the floor. The first question, Barham, where did the idea come from?
Yeah, thank you, Hazem. The idea came from as I scoped thousands of these patients, I realized that the shape, geometry, of the pouch and the anastomosis varies a lot. It varies with time. As we went through different eras of a gastric bypass, it varied, and it still varies with surgeons as well. So it was not as simple as I'm going to give you a guesstimate measurement in 2 dimension of the anastomosis, and that is going to predict everything. It was this complex interplay between the volume of the pouch, the diameter of the anastomosis in 3 dimension. Most of the time, the anastomosis is not in FOS, it's off axis. And how compliant is the anastomosis as well, because it's not only the restriction, but also the communication or the rate by which this pouch empties to the small intestines is an important determinant, because we know that there's beyond restriction, there's important small intestinal pathways at play, mostly the incretin, because we know that most bypass is associated with a quick spike in glucose and quick spike in insulin, and the incretin that comes with that. So to me, it was taking this to a little bit of a more a second level of investigation in order to kind of better stratify patients, to offer them a procedure that would target their physiology in order to maximize benefit of this intervention. And that goes for surgery. It's beyond endoscopy, because what do you do with surgery? Do you distalize the rulum?
Correct.
Do you retrim the pouch? Do you convert? It's not settled, and the reason it's not settled, because I don't think there's one answer for all of this. We need to kind of personalize the procedure choice to the driver in that patient.
So if I'm right, Barhaman, if I'm concluding correctly, you've pretty much given life to the gastrojejunal anastomosis. What you're saying is that it's not a static structure; it's more of a valve, and the way sometimes it could be wide, but people would lose weight in comparison to someone with a narrow anastomosis. It's how this anastomosis respond to the food bolus that determines how good the operation is.
Absolutely. And we lived in an era where surgeons loved this micropouch. It was almost an esophagoduodenostomy that you're dealing with. And these patients had worse outcomes as far as their weight. I don't think they have better outcomes. And then we migrated back to having a good size 5 centimeters pouch with a reasonable anastomosis of about 10 to 15 millimeters. And that is the standard bypass. But yes, this is a dynamic structure. Obviously, it's dynamic because we deal with reactive hypoglycemia. If it was not dynamic, everybody will get reactive hypoglycemia after a bypass, right? But we know that not everybody gets reactive hypoglycemia or dumping syndrome. Only a small portion get that, because this is a dynamic structure. The volume and the compliance of the structure matters beyond just the geometry or the diameter of the anastomosis.
Correct. And I assume this is what you meant when you said compliance of the gastrojejunal anastomosis.
That's right.
Okay, I have a few questions. There's a gentleman by the name of Haider Shabana asking you about the mechanism of the argon therapy in reducing the diameter of the gastrojejunal anastomosis, which you referred to at the beginning of your talk.
Yeah, so argon is basically an ablative modality. It's heat-based modality. It builds a coagulum of argon gas, which basically heats the tissue and create a thermal injury to that area. So the idea is with argon, with repeated treatment, you get scarring and deposition of fibroblasts into the area that you thermally ablated. And that fibrosis decreases the size of the anastomosis, but also it will likely decrease the compliance of the anastomosis, because the fibrotic structure is not compliant neither. So that's the premise of the use of APC, is as a mechanical restriction by inducing fibrosis at the gastrojejunal anastomosis.
Okay, and there's a question about, in your flow chart about the inclusion and exclusion, you talked about other variants of Roux-en-Y gastric bypass. Have you got any idea what that means?
Yeah, so other variants, I mean, obviously this is an all-comer study, so everybody who was referred to endoscopy were eligible. So we did not want any confounder as far as presence of a gastric fistula to confound the results. So these were excluded. Any marginal ulceration were excluded. Any evidence of a short limb with significant bowel reflux was excluded. We tried to only pick the population that is as much homogeneous as possible in order to try to answer that question. Again, you could see that there's a range of eras. The patients were about 10 to 13 years after their bypass, with a significant range there. So there's newer bypasses and there's older bypasses there, and that's the comment. When I've scoped thousands of these patients, I could tell you I'm still amazed by how different this geometry looks in different eras and by different surgeons.
Because that was a point I was going to be coming to, a question about the population you've targeted in your paper were more than 5 years old. And as you say, the technique has evolved over the years. Do you see these conclusions tangible to today's Roux-en-Y gastric bypass?
Actually, more tangible to today's gastric bypass, because I think we have honed down what works. We gave away a lot of the stuff that did not work, like a micro pouch that did not actually performed worse as far as weight loss and caused a lot of other issues with it, including dumping. So I think now almost everybody is more or less creates about a 5 centimeter pouch, a diameter of about 15 millimeters for the anastomosis. And so now I think it's more standardized as far as the geometry than before. And I think the conclusion still stands now even better because of the more standardization of the technique.
Fair enough. And then the other point that's raised, Barham, is with regard to the distendability index of 7. Where did you get that figure from, considering the fact that your study was not powered?
Yeah, absolutely. The 7 is a little bit arbitrary based on the modeling that we've done. So it's that's why I said we need to confirm the results of the study. But you have, we have not had much investigation of what's normative value of the distensibility of a gastrointestinal anastomosis. So that's the first time we look at it in a systematic way. And when you model in order to test a hypothesis statistically, you have to use a cutoff that is kind of segregate the populations. And so that 7 cutoff came from the modeling that happens after we got these measurements.
Fair enough. I've got a question from Dr. Athar. I believe you've answered it, but if you don't mind, let's go through it again. What he's saying is, in your study, what you're doing is you're restricting the food without changing anything to the metabolic effect of the operation. What is your proposed mechanism for changing the diameter or the actual distendability of the anastomosis in affecting the treatment for weight gain recurrence?
Yeah. So again, it's not as simple. I mean, people love to say the metabolic benefit. I haven't seen what that metabolic benefit means. That means the spike in glucose and insulin, it's not necessarily a metabolic benefit. When you have a spike of insulin and glucose, actually in a normal anatomy, we minimize the spikes of insulin because we know that they're not very good to health. So what is that the metabolic benefit? Others might say incretins, but I don't think I've seen a study where it connected or correlated the incretin, whether GLP-1 or PYY, with hard outcomes of a bypass, whether it's resolution of diabetes or any other outcomes. Now, bile acids, that's a legitimate target because there's clear changes to bile acid circulation that has been linked to metabolism. So so what we come down to is we understand some of the physiology of the bypass, and we simplistically understand that it has 2 components. It has a restrictive component for sure, which comes from the gastric pouch and anastomosis, and then it has a metabolic component that we're starting to understand more. And it's not simply a spike in glucose and insulin. It's more complex than that. It includes the gut microbiome. It includes bile acid circulation. It include changes in the inflammatory milieu of the gut. And it includes changes in the gut-brain interaction to affect metabolic rates as well. So it's way more complex than a spike of insulin and glucose. So, but a common feature, I challenge everybody here who does bypass and have patients with the bypass, ask them at 5 years, how much were you able to eat 1 year after the bypass? Everybody will say, I cannot eat much, small, frequent meals, and I feel full very quickly. At 5 years, almost all of them will tell you, I could eat almost a normal sized meal. I'm hungry all the time. So something drastically changed between year 1 and year 5. And that is the loss of restriction. So, and that's where modifying these and understanding what these factors that contribute to that is quite important, because this loss of restriction is clear, and you only need to ask your patient the questions and they'll tell you that loss of restriction pretty clearly.
Yeah, but I think what you've demonstrated, Barham, is the more you know, we realize that we don't know, because you're showing us that individuals with a wider stoma could lose more weight than individuals with a narrower stoma.
When it is within normative values, when the anastomosis is still less than 2 centimeters. When the anastomosis is 3 centimeters, then they've lost all restriction. That's going to be the dominant factor, and you need to modify that. But when it's smaller than that, then yes, the answer becomes more complex than a simple dilation of the anastomosis.
Correct. And I think the response to your statement is, we see it surgically when you go in after weight gain recurrence for a Roux-en-Y gastric bypass with a wide stoma. The afferent limb or the alimentary rim turns into a stomach. It becomes so wide that it could be easily filled with a full meal, as you said, be it a burger, a pizza, rice, or whatever. Absolutely correct. Absolutely correct. Okay, so Barham, I believe we're holding you behind because you've got some work to do. I've got one last question. So we always read and listen to the work you guys produce from Mayo Clinic with amazement and great admiration. How could this be applied to someone like myself who works in a hospital where we don't have such sophisticated technologies to utilize in assessing our patient to follow the algorithms you guys come up with?
Yeah, very good question. And so the technology used here is this EndoFlip. It's becoming kind of widely spread because it's it's non-invasive. So the catheter is very compliant. Placing it is easy, and training people how to use it is also easy, because it's not like training somebody to read high resolution manometry. This is much easier algorithm to administer and interpret. So I think we just need to be patient with innovation and give them time to mature and get to market before we dismiss them. That's the key. Is the innovative process takes time. It starts by a smaller group of people, then it becomes more widely disseminated, and eventually it finds its fit in the market or in clinical practice. And I think that's the case, is keeping an open mind, having a scientific methods, and not being a prosecutor or a preacher, just being a scientist who's open-minded about things, and change your mind as the data comes through, and adopt what's validated by data is the concept. So to answer your question back again in one word, it's have patience with technology and going from there.
Perfect. One last question from Ali Suluki. He was asking, can you tell us again what's the optimal diameter in your views for a gastrojejunal anastomosis? And is there any difference between a horizontal, oblique, or a vertical anastomosis?
Yeah. I'll give you my biased opinion, from scoping, again, thousands of people with gastric bypass. The best anastomosis is the one that is symmetric, circular, 15 millimeters or less in diameter, with a pouch that is reasonable volume, about with a pouch of about 5 centimeters. So some pouch and some anastomosis that is symmetric. To me, these are the people who tend to be less symptomatic as far as all the other symptoms that could come with a gastric bypass. They tend to be happy, and they tend to respond to any intervention to this geometry if you need it. But again, this is my impression based on my clinical experience, and it's not panned out by or not confirmed by a particular study.
Very nicely answered, Barham. Right, Barham, any final comments from your side before we wrap up?
No, well, I appreciate you, Hazem, taking the time to conduct and lead this session. I always learn more than I contribute with these things, and a dialogue between interventionalists and surgeons and physiologists is going to be the key to kind of use the common wisdom or the collective wisdom of the group to push the field forward. So I think we need to keep doing this collaborative approach and innovate together for the betterment of our patients.
I agree, Barham. Agree. All right. I won't take much of your time. I've seen you check in your clock, your watch several times. Have a lovely and a successful session today. For all of our audience, thank you very much for being great. Just to remind you, the session is recorded. You can watch it again on our YouTube channel or on our IFSO Virtual Academy. Obviously, keep the discussion going on social media. I know Barham is very active on Twitter and LinkedIn, so keep harassing him with questions. He'd be more than happy to answer. Not to forget to carry on submitting your abstracts for Melbourne, IFSO Melbourne next year, 2024. Barham, have a lovely and a successful day ahead. Thank you all very much. Have a great day. Bye-bye.
Bye. Thank you.